Dr. Winsberg is a Stanford-trained psychiatrist. She has 30 years of clinical experience and is the chief medical officer and co-founder of Brightside Health. If you followed her career, she's usually 2 steps ahead of everyone else in looking at new ways to bring innovation into clinical care and pushing the boundaries. So she's going to present a comparative study examining the effectiveness of large language models versus expert clinicians in predicting suicide risk on telemental health patients. So the paper is in the chat, but I think again, we have large language models, we have telehealth, we have trying to predict suicide, something very important. So Dr. Winsberg, I'm going to hand it over to you because I think this is a topic anyone, anywhere in the world needs to know about and wants to know about. And you seem like you found a way to do it at scale, perhaps.
Thanks so much, John, and thanks for having me here. I'll go quickly through background here, just because this is a sophisticated audience. But certainly, as chief medical officer of a large national telemental health company, we are seeing staggering rates of suicidal ideation. About 3.2 million adults experience suicidal ideation annually. 3.8 make a plan, and 1.6 attempt suicide. All this in the context of 50% of counties in the US don't have a single psychiatrist. So we've been very interested at Brightside in treating this higher acuity population, particularly with our crisis care program. We've been interested in using data science to do risk prediction with our patients and see if we can assign a risk score to patients or even assign a difficulty to treat score to patients. And most of this is done using structured data from our digital intake that patients fill out prior to seeing a provider. But we were very interested in whether an LLM could be trained to recognize a patient in crisis or even maybe predict whether a patient would experience a suicidal crisis during the course of their care. So with this background, I wanted to share some of the details of a research publication that we published in JMIR this past year that explores how AI might be able to identify and predict whether an individual patient is likely to experience a suicidal crisis or mental health crisis in the course of their care. My colleagues, Christine Lee, Matt Mohebi, and Erin O'Callaghan worked on this paper. So the goals of the paper were twofold. The first was to predict a current and future mental health crisis using patient-provided information at intake, limited patient-provider intake information. And the second goal was to compare the performance of an LLM for this prediction task against a group of trained clinical experts. We talk a lot about the use of AI in mental health, well, healthcare in general. And I think one of the questions is, where do we set the bar? Does AI have to be as good as providers or better? And I would argue better than providers in order to be deployed, certainly without any human oversight, but that's the bar we're going for. And so we tried to set a lower bar here and just see how would it perform against a group of senior trained clinicians. So prior to a patient's first appointment at Brightside, they're asked to self-complete a clinical intake, which includes a host of questions, but it assesses the severity of their mood symptoms and anxiety symptoms and has questions about their current and past medical history. PHQ-9 would be one example of kinds of questions they would be asked to answer, but we do ask them as a subset of the 9th question of the PHQ-9, whether they're experiencing suicidal ideation and are these a vague or general thought or something that they've made specific plans for. In addition to this question in the digital intake, we also ask patients to express in their own words and free text what they're feeling and experiencing and why they're seeking care right now. And so we refer to this as their chief complaint, but this is an area where they can add one sentence up to many paragraphs. And so patients do put unstructured free text in this area. I was very interested in what we could learn from this free text and what an LLM might be trained to recognize in this free text. We also asked the patient whether they've ever attempted suicide prior to enrolling for care at Brightside. And so this is the question as it's seen in their intake. So who did we include in this study? We included patients who completed the intake after March of 2023 and had attended at least one psychiatric appointment or one therapy appointment, and people who had actually entered something into that free text field in that chief complaint free text field. The data was separated into two groups. So one group of patients who had endorsed suicidal ideation with plans, so something they had made specific plans for at the intake or after the intake during the course of their care. And then the second group was a random cohort of patients treated during the same period of time who never indicated any suicidal ideation with plan. We used a HIPAA-compliant LLM for this study, and it was specifically ChatGPT-4 from OpenAI. We had a BAA in place, and only ZDR endpoints were utilized, so there was no data retention. And all chief complaint information was de-identified using Google Cloud DLP. So when the LLM or trained clinicians were presented with information, anything that could have any PHI was stripped out, making some of the chief complaint information, it didn't read exactly like the way you might see it in a clinical encounter because certain features were stripped out. The 6 senior Brightside clinicians were shown a patient's chief complaint and prior suicide attempt history. So first they were shown the chief complaint and then asked to predict whether that patient would likely have a suicidal crisis. And then they were shown the prior suicide attempt information and asked to make the same prediction again. They were blinded to any particular patient information other than what was presented and blinded to the future course of treatment. So they were just asked a simple yes/no question. OpenAI was also, ChatGPT-4 was also provided with the same information as the clinicians and given instructions to predict endorsement of SI with plan in a similar fashion, initially with just the chief complaint information and then with prior suicide attempt information. In order to prompt the LLM to complete this task, we gave it step-by-step instructions and one positive and one negative example. And we also provided the prompt with risk indicators to identify in the text. And you can see the risk indicators that we used here. They were, as examples, recent stress, loss, or trauma, history of trauma, chronic medical conditions, substance use, previous suicide attempts, lack or loss of relationship support, and so forth, family history of suicide. So all the things that a trained clinician might actually look for in a clinical encounter. And the LLM was instructed to be aware of these as they were analyzing the language that the patient was providing. Moving on to our results here. So we looked at 200 patients who did not indicate any suicidal ideation with plan. And we looked at 140 patients who had suicidal ideation with plan at the time of the intake, filling out the intake, and 120 patients who later reported suicidal ideation with plan during the course of their treatment. And there was no significant difference in age, gender, ethnicity in any of the groups. We also didn't observe any significant difference in chief complaint word count between the 3 groups. So the material that was surfaced to either the LLM or the clinicians didn't markedly differ in terms of the volume that was presented. And on average, those that went on to develop suicidal ideation with plan after intake did so on average 62 days after intake. So we were looking at crisis prediction in the 2-month range. In terms of prior suicide attempt data, 7% of the patients who were in the negative category of no SI with plan indicated a prior suicide attempt versus a much higher rate. So close to 40%, 39.3% had a prior suicide attempt if they indicated SI with plan at intake, or 33% SI with plan post-intake. So the clue of prior suicide attempt obviously was more prevalent in the patients who were higher risk. With using the chief complaint text data only, GPT-4 had a higher sensitivity, but lower specificity than clinicians on average. So the sensitivity of ChatGPT-4 was 0.62 versus lower in our trained clinicians, and lower specificity than the trained clinicians, as you can see. So in general, ChatGPT tended to be more sensitive in terms of being able to predict risk crisis. For comparison, performance of just previous suicide attempt as a standalone input to predict SI with plan at the time of intake had very low sensitivity at only 0.39%. So that alone was not particularly sensitive. Performance decreased for the clinicians and ChatGPT-4 when predicting future SI with planned post-intake. And so both parties, the LLM and clinicians, were less good at predicting a crisis in the future. But again, specificity results were consistent with predicting SI with planned intake, and there was no change in the negative samples. We were also interested in the performance of ChatGPT-4 in samples where there was a little or a lot of clinical consensus. So understandably, clinicians are not very good at this task, and there was a fair bit of inter-rater reliability. So some samples, there was more consistency between the clinicians, where clinicians tended to agree on either a negative prediction or a positive prediction. So we took samples where at least 3 clinicians correctly predicted the samples for SI with planned intake. And in those instances, ChatGPT had a sensitivity of 0.91 and a specificity of 0.77. So in the more clear-cut examples, ChatGPT was actually very sensitive and more specific than in samples where there was less agreement among the clinicians about prediction or less accuracy among the clinicians about accuracy. Again, it's just worth pointing out, this is a hard task for humans. And traditionally, we are not very good at being able to predict when somebody's going to have a suicidal crisis. So that's why we were particularly interested in doing this comparison between machine and humans. So interestingly, looking at risk language, even in samples with no further suicidal ideation, there is risk language. So sense of hopelessness was the most common risk indicator. It was in 40% of samples, compared to 27% of SI with plan post-intake, and 16% of no SI with plan. So ChatGPT was able to identify that sense of hopelessness and recent stress, loss, or trauma. These were common reasons why ChatGPT was indicating risk factors in the samples that it was predicting to have a further suicidal crisis. And we did a comparison here, you can see, of all the risk factors that we thought would be valid reasons to predict risk. And ChatGPT was able to tell us in which instances it had predicted risk based on those risk factors. When we assessed clinicians' performance on samples where ChatGPT-4 indicated no explicit risk, the average clinician sensitivity was found to be low for both groups. So I guess this is an indication that in instances where where the language doesn't reveal anything, clinicians weren't particularly sensitive to those cases as well. Going over the limitations and conclusions of this study, we could certainly incorporate a larger and more diverse population. We could certainly have used LLMs that were built for application in the medical domain. And there certainly could have been a greater exploration of prompt design and its impact on performance. But I think what the study did reveal is that foundation LLMs are capable of predicting risk of SI with plan without extensive work. So designing this prompt was rather rapid and easy to do. And they weren't trained explicitly on the task. They were just given one positive and one negative example with some things to look out for. And that the other conclusion is that the variability in the clinician's performance and consensus indicates that identifying suicidal ideation with plan in patient text alone without any other identifying data is a difficult problem, even for trained clinical experts. We also explored in this study the utilization of ChatGPT for the extraction of meaningful clinical information in text, such as sense of hopelessness, that could further assist in identifying patients that might need to be triaged for higher level of care and resources. And while this was not a specific objective of the study, it's worth noting that the average clinician took about 3 hours to do this task, and all reported that it was very emotionally taxing, whereas ChatGPT-4 was able to do this in less than 10 minutes and approximate results with, again, higher sensitivity and low specificity. So as a triage tool, that is super useful in being able to do this rapidly and without any emotional distress. And just other conclusion would be that the use of LLMs for triage should be limited to suggestions and distillation of information, but not taking humans out of the loop. Happy to answer any questions.
Thank you so much for sharing that. I think we're all beginning to see more papers on it, but you had a clinical sample of people in care, you did it the right way, you had a business associate agreement. So it's a very nice example of how to do this work. It's also, as you said, rather impressive that you took something out of the box, right? This wasn't trained, tuned, built. You kind of took a tool that anyone can find it and applied it. And that's pretty remarkable for where it is. So that was just my compliments, I'll say, but we'll jump to the questions. I think one is saying, could you do this with videos if people are, say, recording themselves in clinical sessions, and could you add in kind of new dimensions of data that would perhaps help or hurt?
Absolutely. And it's something we've given a fair bit of thought to. So we are in the process of implementing many AI tools at Brightside. And of course, with these tools, there's always the ethical concern of balancing patient privacy with the potential clinical utility of the tool. So the issue with video recording is that it adds tremendous value, and we could certainly get consent to have patients record a brief description of their chief complaint using and get facial expression data, get tone of voice data, along with transcription data. This was effectively using transcription data. We may move in that direction. For the moment, we're restricting ourselves to transcription data because it can be 100% de-identified. So the transcription data is de-identified after it's collected. And if stored, it's only stored for R&D purposes, not ever able to be tied back to that particular patient. And so it just obviates it bypasses all the concerns around patient privacy that we might encounter with video recording. But there's absolutely a lot more signal in the video.
So that makes sense. And again, the fact that you were able to get those results from just text is alone.
Text alone, and it's amazing. I'm particularly interested. I wrote a book on what we can learn from a person's text messages about things like their personality and attachment style and so forth. And I do think language has a very strong signal, but it's interesting that you can take just a few sentences or a paragraph that a patient writes in, and that's all you're working with, and be able to make a prediction about whether they would have suicidal ideation in the future.
Yeah. One related question, maybe in general, do you think that people seeking mental health care are excited to have AI as part of care? Do they want to see what happens? Or some people say all AI, some people say no AI. Where do you think is maybe just a population we are?
Yeah. And I think we're just scratching the surface of this. We're just learning this at Brightside as we obtain consent from patients about certain features and obtain consent from clinicians about certain features. So we see, in general, I would say people are embracing it, but we see people who are resisting, and both on the patient and provider side. So generally speaking, when it's well explained and you can explain how the data is de-identified and not stored, or stored in a de-identified state, what we've seen is people are really willing to embrace it, and they are more willing to embrace it if they understand the clinical utility of it, how it might impact their care in a positive way, and how it for providers, how it might help them triage, help them with clinical decision support, and help their workflows in terms of note generation and so forth.
I think that makes sense. You're saying it's the way that we go about it, it's the process, it's the approach. And we know just from our colleagues in other medical fields, there are some very invasive medical tests, scans, blood work people do. So again, if we can do it in a trustworthy way, then we prove the benefit. I think it definitely can only be useful if we take the approach that perhaps you are kind of showing us how it can be done, and dare I say, how it should be done with it. So any, I mean, this is a hard question. 2025 is around the corner. You're a psychiatrist, not a fortune teller, just like me. But do you have any predictions of what we're going to see happen in this kind of world of AI and large language models and technology? We won't hold you to it.
Yeah, no, I mean, I think we're going to see an explosion of these tools really developed. As to what gets deployed, that may be slower, but I think we'll see a lot of tools get developed. This one is a particularly easy one because it involves triage. So that's something we're very interested in being able to do effectively. I think we'll see tools that will come into play for workflow, and we already have in terms of scribes that use a transcription of a session in order to note generate and make auto case note suggestions. Chart summaries are another ideal way we're going to see AI come into play, where a provider can rapidly digest the length of a chart or a medical record prior to an encounter. And we'll see those come into play, I know, in 2025. I think that the landscape of having an AI therapist is still a little farther afield. But I used to say that wasn't really ready for prime time. And I think we're seeing these tools get so good so fast that it's going to be interesting to watch what happens there.
Yeah. One final question that I promise this is it for everyone. Do you
Yeah.
think we'll see AI get to a point where humans will not need a background clinician supporting it? Will these AI tools be good enough soon to kind of offer basic supports? We heard in the last talk about NLP is the evidence isn't quite there, but these tools are getting more powerful.
Yeah, so it gets back to the first thing that I said about where do we set the bar with AI? And I would say that the bar needs to be set much higher than clinician performance. So if you were trying to sell self-driving car technology and you told your investors that you were only kind of kill 30,000 people a year, nobody would invest in that kind of technology. And yet that is the rate of motor vehicle accidents with humans, and so I think that we need to have, in order to be able to implement AI without humans in the loop,
Yeah.
it has to be so much better than humans. And so I think that that's going to involve a fair bit of R&D. And so I don't see that happening in 2025, for instance.
I think that's a nice way to end on. There's future room for improvement and more things. So thank you so much, Mimi, for closing us out with showing us what Brightside is doing in the space. And I think for all of you, thank you for joining today.